네, 안녕하십니까. 심포지움을 시작하도록 하겠습니다. 오늘 날씨도 더운데 이런 자리에 참여해 주셔서 대단히 감사드립니다. 그리고 외국에서도 저희가 이 아이소 활동을 저희도 이제 하면서 약간 팬데믹이 좀 쓰러지면서 이제 없어지면 엔더믹이 돼가면서 이런 전문가분들을 초청할 수 있는 기회가 돼서 사실 멀리서 많이 오셨거든요. 그래서 이분들한테도 대단히 감사드리는 말씀 드리고 싶습니다. 오늘 저희 이 심포지움은 저희가 동시 통역을 준비해놔서 질문이나 또는 말씀하시거나 이거 자연스럽게 하시면 영어랑 한글로 이렇게, 그러니까 영어로 하시면 한글로 번역해서 방송을 하고 저기 하고 책상에 놓으신 이 청취기로 통해서 쓰시면 되고요. 저희가 이 심포지움에서 홈페이지를 만들었는데 거기로 웹캐스팅이 됩니다. 그래서 그쪽으로도 이제 보시는 분들 거기서 이제 질문을 하긴 좀 어렵지만 웹캐스팅이 되고 있을 겁니다. 그래서 되고 오늘 이 행사의 아주 호스트라고 할 수 있죠. 행사는 사실 국가기술표준원에서 주로 저희 돈을 많이 대주셔 주셨죠. 그래서 행사를 할 수 있게 됐었고요. 그 다음에 여기 참여하신 이 초록집에 저희가 뒷편에 약간 보시면 안 되면 여러 개 기관들이 약간씩 이렇게 연구비에서 이렇게 쉐어를 해서 이런 심포지움 하게 돼서 이 자리를 빌어서 여기 참여하신 여러 기관의 연구 책임자들 또 전문위원도 또 열심히 하시는 분들이라서 대단히 감사드리는 말씀 드리겠습니다. 그래서 이제 심포지움 이제 오프닝을 할 텐데요. 오늘 이 심포지움을 있게 하신 국가기술표준원의 바이오화학과 표준 과장님을 계신 최정식 과장님을 소개하겠습니다. 환영사를 하겠습니다. 예, 바로 가시면 이거 쓰시면 됩니다.
예, 방금 소개받은 산업통상자원부 국가기술표준은 바이오학 서비스 표준과정 최정식입니다. 만나 뵙게 돼서 반갑습니다. 우리 한국은 이제 그 가을이 이제 시작되는데 어제 오늘 그래도 여름처럼 아주 더운 날씨였습니다. 이렇게 많이 참석해 주셔서 감사드립니다. 팬데믹의 준비와 대응 국제 심포지움 개최를 축하드립니다. 그리고 오늘 이 자리에 온오프라인으로 참석해 주신 여러분 모두를 환영합니다. ISO TC304 의장인 베로니카 무즈키스 에즈워즈 박사님을 비롯한 모든 기빈 여러분 환영합니다. 오늘 이 자리는 엔데믹에서 새로운 팬데믹의 대비라는 주제로 보건의료조직관리 관련 국제표준화 전략을 논의하고자 국가기술표준원과 한국의 전문가들이 함께 자리를 마련하였습니다. 지난 팬데믹은 끝이 보이지 않는 긴 터널이었습니다. 지금은 모든 세계 시민들이 다시 일상으로 돌아와 자유롭게 여행과 여가를 즐기고 있습니다. 이 시점에서 미래 팬데믹을 준비하기 위해 TC304 워킹그룹 4의 회의가 처음으로 대면으로 개최된 것은 큰 의미가 있다고 할 수 있겠습니다. 이 행사를 준비를 위해 힘써주신 워킹그룹 4의 바이오메듀스 대표이신 김종원 컨비너와 한국표준협회 이준환 간사님께 감사의 말씀을 드립니다. 또한 발표를 맡아주실 각국의 전문가 여러분께도 감사의 감사를 드립니다. 이번 회의를 상호 경험과 지식을 공유하고
C304 will become more active by sharing mutual knowledge and experience, solidifying our network in this conference. Ladies and gentlemen, when the world was hit by COVID-19, ISO TC304 showed great achievement with focus and effort in such a short period of time. Working Group 4 was formed immediately in September 2020 to standardize prevention of contagious diseases. 4 ISs are published out of more than 10 proposed by Korea. The rest of proposals are selected as NP and now is in the process of standardization. It was only possible thanks to strong leadership of TC304 chairperson and full support and participation of member countries. I am grateful to see Korean proposals becoming best practices and accepted by many countries in fighting against an unprecedented pandemic. As you are well aware, pandemic changed the way economy, society, and life works all at once. Although we finally came out of the 3-year-long tunnel and are now moving to the era of endemic, we all know that none of us are free from next pandemic completely. WHO and scientists are warning us that there will be more frequent public health emergency of international concern and contagious diseases. That is why TC304's work must be recognized and continued to tackle global challenges. Ladies and gentlemen, Korea will continue the international standardization work for preparedness and response to pandemic as we have been. Need for international standardization will only increase in pandemic preparedness, which requires more experts in Industry 4.0 such as ICT and robotics to further enhance standards. Establishment of subcommittee for more systematic and careful standardization work might be required. We'll continue to make our efforts on various fronts. No one knows how and when the next pandemic will hit us. I strongly believe health specialists here are heroes, protecting mankind and its safety and prosperity.
오늘 참석해 주신
Thank you very
모든
much for
분들께
joining
다시 한번
us once
감사드리고
again. I wish
여러분의
all of you the
건강과
best of luck
기원합니다.
and health.
감사합니다.
Thank you.
네, 최정식 과장님의 환영서였습니다.
Thank you very much, Mr. Choi, for the welcoming remark.
그 초청을 해서 이 자리에 모시려고 했던
Where our original intention was to invite
의장님이
Dr. Veronica Edwards, who is the chairperson of TC304 today here in Seoul. But unfortunately,
이번에 초청하다가 못 오신다고 할 때 우리가 한
she
3,000명 정도
is running a business
한국에 가서 한
which
3, 4일
have
보내는 게 쉽지는 않다.
forbidden her to come here in person. She really wanted to come to the symposium herself, but it is very unfortunate to not have her here today. So Dr. Edwards have sent us a video of her congratulatory message.
Hello, my name is Dr. Veronica Edwards, and I am the chair of the International Organization for Standardization Technical Committee 304. Our global scope of work includes standardization in the field of healthcare organization management, comprising of terminology, nomenclature, recommendations and requirements for healthcare-specific management practices and metrics, including healthcare quality management, infection prevention, and pandemic response and management. The day the World Health Organization declared COVID-19 a global pandemic was an extraordinary moment in time that brought together extraordinary experts. Our regional experiences may have been different, but together our objective was to create pandemic response standards to help medically underserved populations and under-resourced communities respond to and manage pandemic response scenarios. On behalf of TC304, welcome to the International Symposium on Pandemic Preparation and Response. Please know that your participation today is noteworthy, appreciated by public health experts and the communities they serve, and future generations. I'm honored to introduce the Korea Agency of Technology and Standards and the Korean delegates of ISO TC304 as they share their leadership experiences and pandemic response and management standardization initiatives. I thank CATS for their service, their perseverance, and their vision, and I also thank those of you that have worked so hard to make this event possible. I encourage each of you to become involved in the development and the adoption of pandemic response and management standards, and I thank you for inviting me to be part of this wonderful event.
이상으로 그 축사를 마치고
That marks the end of the congratulatory message. The first presenter for the first session will be delivering the keynote address. We will invite Professor Sunju An on the podium for the keynote address. Her presentation will be under the title that goes the same as the title of our technical committee. To briefly introduce her presentation and our presenter, she's currently at Seongjungan University and is the founder of the ISO TC304 Working Group 4. She runs many projects currently, and already 3 projects have been published at the ISO. And in 2023, she was awarded Excellent Expert at the ISO. In terms of pandemic standardization and response to pandemic, Professor An will be giving her presentation.
Well, thank you for kind introduction, Dr. Kim. It's my great pleasure for being here today, and thank you for here with us, for being here today. And like what convener Dr. Kim, Mr. Kim said about the foundation of the ISO TC304 Working Group 4, I'm a founder of Working Group 4, but I think the Dr. Edward Veronica, the chair of the TC304, and all experts. The collaboration and contribution were there with us, and I appreciate that. And today I'd like to talk about pandemic preparation and response. Actually, this is the original title of Working Group 4. So there is no screen, so yeah. Yeah. Let me briefly summarize what happened the last 3 years and what should we do for the next pandemic or endemic or public health emergency of international concern. So the reason why are we here is to gather together and share our expertise for next pandemic and endemic. Actually, in COVID-19, how was the COVID-19 pandemic changing our life during the last 3 years? Most of social gathering and family gathering were canceled and postponed, sometimes replaced by Zoom or WebEx, some kind of online event. At the very early stage, in my memory, we have reviewed the WHO guidelines for pandemics because we could not find relevant to tackle this kind of novel virus-caused pandemic. But unfortunately, there are many valuable guidelines, but there were no specific guidelines or norms or standard operating procedures for the time being to help the public health authorities and laypersons protection from the new kind of virus, SARS-CoV-2. So we started to review national and international organizations for public health. They released the set of lists for influenza or other kinds of pandemic or endemic, but the level of detail is not quite helpful, actually. And finally, we visited the international website, for example, online browsing platforms, and what standards are available for this kind of new threat, new disaster. How can you use that? But it contains the standards-related PPE, personal protective equipment, and sometimes IPC measures were developed in the standard. But the rest of the standards are not concrete and sufficient to immediately use that. So let us think about it. The COVID-19 pandemic, in early stage, there were no valid vaccine and effective treatment. We could use the hand-hygiene PPE, personal protective equipment like mask and social distancing. But fortunately, through the pandemic, the international society, including Korea, have devised and developed new kind of novel MPIs. What are MPIs? Non-pharmaceutical interventions that are actions apart from getting vaccinated and taking medicine, which people and communities can take to help slow the spread of illness like pandemic, SARS-CoV-2. So many public health practitioners, including Kim Jin-yong, Doctor Division of Infectious Disease, devised drive-through screening station. I believe you have already experienced or seen the DTSS. The DTSS is specialized for large-scale mass specimen collection and testing for COVID-19 patients or suspected case. So what are the purposes of DTSS? Identify people who are infected, minimizing contact among patients and providers, healthcare professionals, saving time in specimen collection, to reassure people who are not infected, and to educate them about precautions. This is the last, not the last one. So when he started the DTSS, when he launched this DTSS program in South Korea, after that, several countries immediately utilized that model. And also, for patients who don't have their own car, we devised the WTSS, or walk-through screening station. You can see the Dr. Yohyun An and Sang-il Kim. They developed. It's like a telephone box, the small box, yeah, and that allows quick collection of samples at patient or people under investigation. Walk through the station with minimal contact, and actually we published this standard, including the DTSS, to help the international society. Dr. Hernandez, actually, he's not here for the individual reason, but he gave us comment, oh, please make this progress as soon as possible. We would like to utilize that, including TMF. I can explain what is the TMF in a moment. So, many countries deployed the walk-through screening model in their country. And what is the temporary medical facility? That is a quasi-hospital, mostly for mild or pre-symptomatic or asymptomatic confirmed cases who have been discharged from hospitals, or they could not find, if they could not, the bed in the hospital for intensive care. Usually at that time, hospitals is specialized, focused on treatment for severe case. So we have included these criteria, admission criteria, discharge criteria, and high-risk groups are excluded in this, admission for temporary medical facilities. And in TMF standards, we included the designation methods and how can we operate without any delay in the terms of when it comes to the public health emergency of international concern. Those facilities provide staffing, healthcare workers, and patient management, and hygiene and laundry, meal box provided 3 times a day, and also supply the medical services. I don't have a pointer. Anyway, if suspected case admitted to TMF, he can take the chest X-ray, whether the disease, he or she is a patient or not. And one of the interesting is that every inpatients in TMF should be monitored remotely without contact with healthcare professionals through the self-symptom checker app or a personal health record. You can see the red circle. That means the person has symptom related to COVID-19. So with great contribution with the many people in the world, and CATS and Dr. Kim, convener, and Juran Lee, secretary, we have published 4 items so far. And some projects are ongoing. For example, contact tracing or the infection prevention guidelines for vulnerable people. And I'd like to finalize my presentation. Recommend the future direction of the Working Group 4's agenda. This is just a provoking suggestion. Actually, Working Group 4 members were heavily dedicated to pandemic response-related standards so far until now, and we need to continue this kind of valuable work, and future contribution areas could be summarized into 3 parts: structured or standard operating procedure for non-pharmaceutical interventions, and discover and develop new public health measures using AI or robot, cloud computing, virtual reality, something like that, and proactive contribution to the international goal, such as Millennium Goal. So a good thing is that during the pandemic, many diverse non-pharmaceutical interventions were deployed and developed nationwide and internationally. So digital imaging and AI, hospital information system, robot, telemonitoring, cloud computing, virtual reality, combined with healthcare business. So we need to focus, how can we develop the valuable standards to contribute to international society when in terms of public health threats? That is my suggestion. Yeah, I'd like to thank you all, and especially the cats were the #1 government supporters. I'm very touched their dedicated activities and supporting. And also, I'd like to finalize my thankful message to all of you, because without your helpful comments and contribution, we could not make valuable international standards. Thank you very much.
A lot of time, but we'll be able to entertain 1 or 2 questions before moving to the next presentation. If there are any questions, please raise your hand. We will get the microphone to you.
지금 우리 과장님도 그렇고 안 교수님께서
As director and Professor On mentioned,
팬데믹이 이제 계속 나타날 거라고 저희는 이제 예상을 하고
there will be new threats and new pandemics in the future. Currently, there is Working Group 4 for pandemic and proposed standards. Once all the work is done, the Working Group 4 will be dismantled. And after that, to work on further standards, are there any other programs in plan? It's a future, forward-looking question. Thank you. The pandemic is now over, and many people are curious about the role and responsibility of Working Group 4. But actually, we are still under a lot of items which require standardization in our daily activities. How can we do the control of the infectious disease? We will continue to develop best practices. So that's the initial scope. We had a short discussion among internal leadership. And healthcare organization management is the area for Working Group 4. Each hospital has ICT, AI, and robotics. They're leading innovation. And COVID-19 expedited this expansion. MOXIE is a delivery robot, for example. And in the past, drugs and relay services were distributed by the hospital personnel in the future. But MOXIE, which looks just like human, will do the delivery. So there is no human-to-human contact. This, the satisfaction level of this service is very high. And remotely, you could download the X-ray from cloud environment. The service is already commercialized. So if you remember the very last slide, do you remember the different colors on the slide? Various emerging technologies will be integrated into healthcare organizations. So on that front, there will be new standardization required. Convener Kim mentioned this in the morning session. The scope of Working Group 4 must be expanded and enhanced. So the scope will be expanded and further developed to make sure there are necessary standards established for health organizations. And through those activities, we will be able to make more contribution to the international society. We have lots of representatives from government agencies, and Chairperson Dr. Veronica is very much interested in this tasks as well. So along with international experts, we'll continue our discussion to further develop the scope of Working Group 4. Though the pandemic is over, many public health scholars and experts are warning us that there will be emergence of new viruses and new pandemics. So we need to prepare for those challenges. So that's what we are going to do in the future. Thank you for your question.
다른 분들 질문 혹시 있으시면
Any other questions? We will entertain one more question if there are any.
그러면 없는 거고 또 이메일 어드레스.
If not, you have her email address, so feel free to ask questions later. We'll complete the first session here.
보내는 거에 대해서.
And so the second session would be sharing pandemic responses from other countries. But before that, we would like a warm-up round of applause for presenter An. The second session will be moderated by Ms. Juran Lee. Thank you very much. This is Juran Lee, working for the ISO TC304. I am the moderator for the second session. As Professor An has mentioned earlier, we have a lot of participants from the ISO and the Korean experts for this event today. And for the very short period of time, we published 4 ISO items. For those of you who have come in late, the channel number 1 on your receiver is for Korean language service, and the channel number 2 is for English language. So you'll be able to hear the simultaneous interpretation via your receiver. So after each presentation, feel free to ask any question in a language that you feel comfortable. So first presenter for this session will be given by a presenter who actually had a 14-hour flight yesterday. Let me introduce an expert from Poland. The first presenter is from NobleCert, which is a consulting management company based in Poland. And we will introduce Mr. Piotr Fermanek, the CEO of NobleCert. At the IOC TC304, Mr. Fermanek has been the convener for Working Group 7. In addition, he has been working at universities to lecture on standardization and technical standardization. So please welcome Mr. Fermanek with one round of applause.
Good morning to everyone. 안녕하세요. It's a great opportunity and to participate with this symposium. Very grateful to ISOTC working group for fundator and convener and secretary for this invitation to be here today. I'm very happy to present how Poland responded to the pandemic and what challenges await us in the future. In 2020 has shown us the first challenges and needs. Additional human and material resources, simplifications of procedures, and great opportunities, digital transformation. During the period between March and the end of August 2020, following the introduction of right restrictions, the incidence of COVID-19 remained relatively low. No peak of the first wave was observed in Poland. Instead, there was a gradual increase in the number of cases and deaths until mid-July 2020. The partial easing of certain restrictions as well as lack of compliance with those still in force resulted in another surge in cases in spring 2021. COVID-19 vaccinations was already underway during this period, but the vaccination program was slower than anticipated. Another wave came in the autumn of 2021. The pattern of distribution of the epidemic changes from a focal one outbreak concentrated in a dozen or so districts to one diffused throughout the entire country. In epidemiological threat forced the introduction of certain solutions, including restrictions, orders and prohibitions in various areas of daily life. The purpose of such measures was not only to limit the transmissions of the virus, but also to relieve the burden on the health care system. This allowed time for the implementation of new regulations and redistribution of health system resources. The Ministry of Health established a steering committee and an expert panel. Documents regulating the tasks of public administration bodies, as well as the powers and responsibilities of healthcare institutions and patients, were drawn up. This allowed us to ensure proper access to diagnostics and treatment for patients. The territory of Poland was divided into green, yellow and red zones, depending on the number of COVID-19 infections. A national registry of COVID-19 patients was established to control potential outbreaks of infection and allow for the long-term follow-up of patients. Procedures for the delivery of service depending on the status of viral transmissions were developed for the purpose. 4 stages of transmission were identified. A home quarantine was introduced for patients with confirmed positive result, as well as an automatic quarantine for persons staying in the same household as the infected person. And how we can see, a network of dedicated COVID-19 hospitals was established. There were used an addition to the existing infectious disease wards of other hospitals for treating infected patients. In April 2021, almost 45,000 beds were available. The total number of occupied beds reached around 78% in November 2020. A bed-based expansions model was also introduced. The COVID bed base was increased by adapting some district hospitals and internal medicine departments of provincial hospitals, involving private hospitals, as well as by organizing temporary hospitals in public buildings as stadiums or hotels. Due to the insufficient number of infectious disease, specialist primary care physicians were involved. Based on the result of the telemedicine call, they could refer the patients for COVID-19 test. They also supervised the health status of patients through telephone consultations. Remote monitoring of oxygen saturation level was introduced for patients at high risk. The solution replaced the original model in which staff on infectious disease wards were responsible for patient care. Additional human resources, including medical students and retired medical staff, was also mobilized. Sorry. Yeah. The availability of COVID testing was increased by allowing testing at stationary points, including pharmacies and mobile drive-through points. This increased the diagnostic capacity to 192,000 tests per day. The highest priority was given to hospitalized patients with symptoms of infections and the healthcare staff. By the 11 June 2023, around 58 million vaccination was being carried out in Poland. More than 21 million people were fully vaccinated, and almost 14 million people were vaccinated with a booster dose. And let's move on the digitalization. I'm sorry. Yes, sorry. Yes, that's the numbers. What I say before. And digitization. The pandemic accelerated the development of e-services and the area of healthcare, enabling access services and patient monitoring while reducing the risk of infection transmissions. E-services project continue to operate and being expanded as follow. Firstly, online patient account. Users with a registered online patient account have access to health information such as the results of ordered tests and electronic prescription. they can also make an appointment for a vaccination and download a vaccination certificate. Secondly, a telemedicine platform enabled video and chat consultations as well as uploading of multimedia files. When it comes to specialist care, telemedicine consultation accounted for 16.2%. It's 16.3 million consultations. Thirdly, home medical care, called DOM. Projects implemented as a part of home medical care, and this project involved first contact teleplatform, telemedicine armband, e-stethoscope, and e-spirometer by the monitoring of patient healthcare, state. Finally, Stop COVID application. The purpose of the application was to quickly isolate infected people and those with whom they had close contact. The application was mandatory for those infected and quarantined. And we have material resource. Polish textile factories and spirits manufacturers switched their activities to the production of masks and disinfectants in order to speed up the procurement of medical equipment. The public procurement procedure was simplified, and reported demand for mechanical ventilators, cardiac monitors, and other equipment was processed urgently. Poland joined the EU tender procedure which provided for the joint procurement of medical countermeasures. It's called Joint Procurement Agreement. Okay, and take a look at social impact. The data you see is shocking. The number of adult suicide attempts in 2021 increased by almost 15% compared to 2020. And even more, dramatic increase was observed among children and adolescents. The number of cytological examinations decreased by 39%, while mammographic examinations by 27% in 2020, compared to the previous year. There was also a 20% decrease in new cancer diagnosis. Counteracting the spread of the epidemic, mainly through lockdown, has had a major social and economic impact. Those who found themselves in a particularly difficult situation were workers of the service sector. A significant number of them were laid off. The establishment of dedicated COVID-19 hospitals resulted in a reduction in the admission rate of non-COVID patients. The number of hospital treatment services fell by almost 25% in 2020. The number of preventive and diagnostic tests also fell, as did the number of new cancer diagnoses by around 20% in 2020 compared to 2019. The physical activity level of almost half of Poles was lower compared to the pre-pandemic levels. 1 in 4 respondents admitted in spring 2021 that they had gained weight during the pandemic. Average life expectancy in Poland dropped by more than 2 years in 2021 compared to pre-pandemic levels. On the positive side, The availability and popularity of e-health services like telemedicine, e-referrals, e-prescriptions increased. And preventive measures in case of future pandemics, assurance of high qualified personnel seems to be the key issue. The healthcare capacity, including equipment, infrastructure and human resources, should be increased, taking into account that it takes a number of years to train medical staff. Medical staff qualified outside the EU should be allowed to work in Poland. The right balance between telemedicine, which many patients have become used to during the pandemic, and the direct contact with the physicians should be maintained. Training courses on vaccination and COVID-19 patients, care for physiotherapists, pharmacists, and laboratory diagnosticians should be organized. Vaccinations program should be promoted among the population. The more people vaccinated, the fewer deaths. And on the last part. This is Hanka. Hanka is 7 years old. She was adopted when she was 1 year old. As always, but especially during the pandemic, pets helped us get through the difficult times. Hanka also helped by sitting next to me when preparing today's speech. Thank you very much.
예, 한카 귀여운 고양이에 대해서 말씀해 주세요.
So there was a short comment about Hanka, cute cat. Are there any questions from the floor?
I have a couple of questions regarding your presentation. You mentioned about the social impact regarding when it comes to child suicide attempt. What is the? Do you have any evidence? The reason for that in your country, and how can the Poland resolve and address this kind of mental health problem for the next pandemic? You mentioned about the e-health was nationwide adapted, implemented during the pandemic. How about the next pandemic? I can see I could not find the actions for the future pandemic. There is no agenda for child suicide attempt prevention. So please, would you please elaborate on that? Thank you.
We're still in progress with looking for the solution of these situations, because it's not easy to capacity of the sources medical staff to start again the prevention program and open for more patients like before. It's really hard. So it's also a challenge for us, and we're still working how to expand the possibilities for more patients. Also, I am cooperate with Ministry of Health in the prevention program, how to increase the examinations. So I can say we are in progress in work to looking for a good solution, not best solution, because it's really not easy. As I told, we engaged retired medical staff. So this is a solution, one of the solution who helped to capacity of the system.
예, 혹시 추가 질문이 있으신가요?
발표 감사드립니다.
Thank you for the presentation. I want to ask a question about the application Stop COVID. As far as I understand, the application is regarding monitoring the whereabouts of the confirmed patients. We had a similar application here in Korea, but one of the concerns was related to the privacy of each patient. To track down somebody's whereabouts is highly related to privacy and personal information. So was the application well accepted in Korea, in Poland?
Yes, the data and privacy of patients is also one of the challenge. Thank you for these questions, but because right now also we have a as I mentioned medical healthcare application where patients could preparing for a visit to taking e-prescriptions, and some patients doesn't want to registering in these applications, and we have a part of the patients that doesn't want and not using this. Also with patients who are not using the internet. That's the group of patients who have to ask children to help them. So there is a problem also for the government how to find the solution to expand this group of patients and ensure the patients that the data are really privacy. So there is also the part of patients who don't want video chat by video or just by the application. So I think always we will always have the part of a group who don't trust the system. That's also the problem, how to build the consciousness of this group of patients.
예, 고맙습니다. 시간 관계상
Thank you very much. Due to the time constraint, we will finish this presentation with 2 questions. We do have coffee break coming up in our schedule, so when you have additional questions, please feel free to ask during the coffee break. Thank you once again for Mr. Fermanek.
유럽 대륙
Next, a presentation. So it was European case, now it's Chinese case, the pandemic preparation and response of China. The speaker this time is from China National Health Development Research Center, Vice Director, and also he is Director of Center for Collaboration and Health System Strengthening in WHO. He is a vice chairman of editorial board of China Hospital Management Journal. He was also visiting professor at Harvard University Medical School. Let's invite Dr. Go Gan to hear about Chinese case. Please give him a big hand.
Good afternoon, ladies and gentlemen. It's a great honor to be here to attend this great symposium. And thank you, Mr. Chair, for the invitation and give me this space to present China's practices and exploration in standardization process of a health sector. Just like I mentioned this morning, we are the new one for TC304. And furthermore, unfortunately, I'm not an epidemiologist, but a dermatologist. So I would like to present in a different direction. So I would like to elaborate on 3 aspects. The first is standardization in China. The second is brief introduction of my organization, then some suggestion to our PTC. Okay, firstly, I would like to introduce the standardization of the China health sector. Standards in China are divided into 5 categories: national level, ministry level, local level, group level, and enterprise level. In the field of healthcare, multiple national standards have been developed, such as medical architecture, medical equipment, medical personnel, and medical services, as well as ministry-level standards. We have established 21 committees, such as medical and healthcare institutions, public health, key population health, etc. These committees are responsible for promoting the development of ministry-level standards. This is a brief introduction about the current situation of Chinese domestic standardization in the field of health. Then we move to section 2, my organization, CNHDRC, which means the China National Health Development Research Center. We are the think tank engaged in policy research in the field of health. By the way, I'm the DDG of this center. We have been committed to promoting standardization work in the health sector in China. See, we actively promote international standardization work even before we take part in this group. You can see we served as a liaison unit of the WHO CNH 127, which means Health System Cooperation Center, and the CNH 125, which means a categorization, nomenclature, and standard cooperation center of WHO. We worked with WHO to promote standardization in health. Moreover, we also participate in drafting multiple international documents, such as the Healthy Asian Pacific 2020 initiative. And in the other side is the last month. During the APEC 2023 conference, I delivered the speech on unified health and economy on behalf of China. Domestically, we participate in various relevant standardization committees, contribute to the development of the national and the ministry level standards, and actively promote the formulation of group standards. We have developed many national level standard policies, covering areas such as cost and payment, medical services, and the construction of healthcare institutions. Some of these standards takes years before implementation. It's a long way. In terms of the research area, I just mentioned we are a research center. I mean, besides international standardization, we actively engage in the multilateral cooperation and build a multi-level research cooperation network. We maintain the close cooperation and communication with countries and different institutions worldwide, such as the WHO, like World Bank, UNICEF, Johns Hopkins, and the KSA now. And then we move to the last section. It's about suggestion. Currently and in the future, both China and the world are facing health challenges. Firstly, life expectancy continues to grow in China, from 76.34 years to 77.93 years in past 5 years. It means a huge amount of people. I think it should be in the history, the largest amount of elderly population in human beings. It also means a high demand of the health. Secondly, the chronic diseases are still the main factor affecting the health. It's a major component of the death ratio in China. And currently, it showed a trend of a low age recently. Lastly, according to relevant studies, in the past 20 years on average, a new type of infectious disease has appeared every year. And some infectious diseases that have been controlled or eliminated were re-emergence. The global pandemic of new infectious disease, for example, COVID-19, has made people all over the world realize that the world is a closed community. I think this is one of the reasons why we're gathering here to discuss. And in the future, we think you are one of us, and we are one of you. In response to the changing demands for public health in new era, China is actively promoting the Healthy China strategy by implementing various measures such as institution reform, chronic disease managing, and so on. China also has implemented the Healthy China Action Plan in 15 key areas, includes health education campaign, nationwide fitness initiative, elderly healthy promotion activities, and NCD prevention and treatment initiative, and so on. I think we have 5 suggestions based on Chinese experience. Number 1, adheres to the concept of win-win cooperation. China practices the vision of a community with a shared future of mankind and take practical actions to promote global health. The country is committed to team collaboration, joint efforts in epidemic response, and active participation in the work of international organizations. In the field of health, such as ISO and WHO, Number 2, bring international standardization expertise together. Experts play a vital role in the standardization process. China aims to assemble a more professional team of experts, gather stronger forces to promote international standardization work, and contribute to global health with Chinese intelligence. Number 3, it is very important to deepen international partnerships. Within ISO TC 304, China actively fulfills its responsibility as a P member country. We hope to deepen cooperation with other P member countries and all member countries in the future. Suggestion number 4, actively promote collaborative research. By prioritizing research in areas urgently needed for the global population, we actively foster international cooperation in standardization. Number 5, emphasize the cultivation of an international talent pool. The field of international standardization demands comprehensive expertise. It is necessary to develop talent cultivation plans. And by the way, China will establish an expert database to train professionals in standardization in the future. So finally, thank you again. And we look forward to the further cooperation with you guys in the future. Thank you.
예, 감사합니다.
Thank you very much. Any questions from the floor? Comments, questions? They're all welcome. No questions. Thank you very much, Dr. Kan.
예, 다음 코너는
The next presentation is on the United Kingdom. To introduce the presenter, in 2012, do you remember the London Olympics and its opening ceremony? It was a very memorable ceremony. I remember watching it on television. The late Queen Elizabeth II and the 007 reenactment was very memorable. And many achievements of UK in the modern days after the Industrial Revolution. And one of the achievements was National Health Service. After the end of the Second World War, the British people were suffering from the ashes of the war. And in the midst of such difficult situation, UK was able to use the tax money to provide quality medical service for free to its citizens. So it was a very memorable image for me, and I would like to ask an expert from the National Health Service of UK for a presentation today. He worked for the BSI AI Standardization and Health Management Organization as an expert in the Mirror Committee. So please welcome Mr. Stephen Bembo from National Health Service UK. Please welcome Mr. Bembo.
Thank you. Good afternoon, and first of all I'd like to say thank you very much for the warm welcome and the invite to be here today. So, that ugly mug up there is me. That's me in my day job. I work in critical care across a number of services within the NHS. But what I'd like to do today is narrow it down to a little bit more of a little local story. So I'm from a county called Herefordshire. Hereford is a very rural county. It is predominantly agriculture. There is literally no engineering or manufacturing. It is purely just arable, good old-fashioned fruit farming and cattle. One of the things we know about Herefordshire is that we have a very ageing population. We are more than the national average for age of people, and that's reflected in our healthcare services. Additionally, we are scattered across 842 square miles with only a population of 193,000 people, in comparison to London, where it's 9.9 million over 671 square miles. So when you take someone from Herefordshire and you put them into a city, they get really, really quite scared because they're not used to seeing so many people. We also have quite a considerable obesity problem within our own county, and that's because of poverty. And we have a significant amount of poverty with people working on the land, and that's a time gone well-known issue that people that generally work on the land who are picking fruit and sowing crops are generally not as well paid as those in industry. So as I said, we got low productivity because the skill set is very low, but equally the pay for our people is very low as well. So 1 in 3 are below the national average salary. The average reading age of our population in Herefordshire is of a 12-year-old. So for our patients and for our communities, we have to make sure that we write it at a level that a 12-year-old would be able to read and digest. And because we have poor infrastructure from industry, we have a low amount of money going into our local government, and that reflects in the services that we can provide to our population as well. However, one of the additional problems we have is the price of property in the United Kingdom is exorbitant. It's very, very expensive, and affordable homes in our county are very difficult for our population. So during the pandemic and towards the end of 2020, the government used an initiative, and it was called eat out to help out. But it wasn't that successful in our county because people didn't have a lot of expendable money. So it wasn't the success that they wanted it to be. But one thing you will see on the map is that there are 3 counties in Herefordshire that are still grey during this period of time, whereas the rest of the country is either blue, dark blue, or purple. And the reason why those 3 counties are grey is because they were the last counties to be locked down. We didn't get locked down fully, and in comparison to some counties that were locked down for several months. We was only locked down for a matter of weeks. Because believe it or not, people don't go out. They didn't go out. They didn't go out and socialise. So there was no spreading of COVID in comparison to other parts of the country. When we actually look at the data, though, there's some things, and this is just purely of Herefordshire, and this is over the period of the pandemic, is that at the start we did have high numbers of deaths within our community, and predominantly within the elderly, and it was the elderly that were being affected. Once we started to get a grip of treatment and knew what we was doing, I think, to be perfectly honest, survivability of these patients become greater. But one of the things that we did notice, more than anything, is that as we researched what the government said our daily figures for COVID deaths, actually when we reviewed it over a 5-year period, these were the same as the seasonal flu outbreaks that we would have each year. So we wasn't seeing this massive rise of deaths that was being portrayed in the media. In fact, what we were seeing, it's the same as what was seen in Poland. We had a reduction of 25% of people coming to our hospitals. We were sitting in our departments going, where's the chest pain gone? Where's the stroke gone? Where are these patients? Why are they not presenting? So, UK pandemic deaths to 228,000. That was Spanish flu. Now, we're all here talking about COVID, and I've put a slide up for Spanish flu in 1918. There's a reason for that, because that was the planning for the United Kingdom going into COVID. They planned it the same way as what they'd learned from 1918, and it was the wrong plan. So at the top of our planning, we have the UK risk register. And at the top of that, at that time, 2 things had been identified. One was a terrorist attack with a chemical, biological, radioactive or nuclear device. And the second one was a pandemic. But all the planning was around flu. It wasn't around anything else. It was very, very just structured on 1918. The one thing that is different from 1918, though, if you look at the picture on the right, you can see people going about their activity of daily living by reading their newspapers and getting their news as they go to work. When you look at today, on the left-hand side of that slide, everybody's looking at their phones. I noticed it last night when I went out and walked around when I got here, and I saw the amount of youth out and about, and where I was walking around looking up in awe of all the buildings like this, everybody was looking down on the floor, and everyone's transfixed by what's going on in the now in their phones. The truth is that what we see, unlike 100 years ago, is we are part of the news. We make the news. We're giving the news. We're providing that data. Whereas before, if there'd been a train crash or a plane crash or something disastrous, we would have to wait at least several hours before a news crew could arrive and capture the carnage. Whereas now, people are transmitting it live as it unfolds. So as I said, our planning for the pandemic, COVID-19, was exactly the same as 1918. And the slide on the left shows you a temporary medical facility set up in 1918, and the one on the right is Manchester 100 odd years later. No different, exactly the same. The only difference is there's nobody in it. And the reason why there's nobody in it is because the patients that needed the care had comorbidities. And we had set our healthcare system just to receive patients with COVID. Whereas the patients that needed proper, definitive, around-the-clock care often had comorbidities, which made the challenge even greater. But therefore, the temporary medical facilities were not used. Also, what we know is on the right there is a heat map, and that's a heat map of media. So we are all driven by data. We're driven by Twitter, we're driven by Facebook, LinkedIn, lots of different ways that we receive our daily fixture of what's going on. And it's, as I say, it's ongoing. Some of you are sat here now probably sharing photos of this meeting to colleagues elsewhere in the world. This is a snapshot. It's not a great slide, but it gives you a snapshot. This is just somebody in my hospital where we're looking up Twitter, Facebook, of where people are leaving instant reviews. Whereas a generation before us, they would write a strongly worded letter to the chief exec and say their displeasure. Whereas now people are writing their displeasure while they're sat in the waiting room thinking, I haven't seen a doctor yet, I've been here 20 minutes, this is not good enough. I'm going to tell everybody on Twitter. The thing about that is, though, sometimes we do see positive news. But when we see positive news, it's the same as when we go out to eat in a restaurant. If we have a good meal, we'll tell one person. If we have a bad meal, we'll tell 6. Because bad news is generally shared more than good news. So in this case, where we've got poor treatment of a patient or someone's not happy with the level of service they've had, they will share that information. And what we see is that information is then reshared. And this is what we started to see at the beginning of the pandemic. Because we had the rise of the influencer. Now, I'm sure you've all seen these people that will tell you their thoughts, their aspirations, and they're famous. They make a lot of money. They will create a brand. They can also destroy a brand. And they are every part of society. We see them every day. But they are reaching everybody. And this is where we have to be careful with our rhetoric around healthcare. So one of the things that happened at the start of the pandemic is I got invited to become a WHO INTERNATiONAL manager. And we was all picked because of our unique backgrounds, and we were all classed as unicorns, in that a unicorn is a rare, mystical creature that is very, very special when you get hold of one. And they called us unicorns for that reason. And what we did was we worked together, collaborated, and we worked through data. And the data is really important. And what we learned in the UK is that a lot that was coming from our own politicians was misinformation. Some of it was malinformation. And we later went on to find out that our politicians were actually not complying with the same rules that they'd set out to the citizens. So while we was all sitting at home and not socialising, they were getting bottles of booze brought into 10 Downing Street and partying. I'm sure you've seen that on the news. Equally, the data that comes out where the popularity of services and governments are affected by everything that's gone on through Twitter to Facebook. And a story can be passed 3 times before it is generally seen as being real. So once that story has been passed 3 times to 3 different people, it generally gets believed as being true. So as INTERNATiONAL managers, we utilise the tools to try and break down and find the source and see if the story was actually true. And we found a lot of things that were quite bad during COVID. One of the things that we did find that was quite bad during COVID was the local issuing of contracts by our government to friends and families. And on the front line in the hospital, we we struggled with PPE as some other countries and nations did. We had FFP3 masks that didn't fit properly or didn't work. They had the wrong valves on them. We had aprons that just didn't work, or gloves weren't to a good quality. And it's because we had these contracts that went out and they spent millions upon millions of pounds on PPE that was absolutely useless. And the point of that is that when you look at your hierarchy of needs in putting safety in place, PPE is at the bottom. Policies, procedures, governance, standards are all at the top. And no one was adhering to any of the standards that had been laid out or been given before. So moving forward, I think, picking up from our colleagues here in the rest of the room, the mental health aspect was something that we certainly noticed. We had in the UK a lot of mental health issues. Suicides equally were significantly higher. I spoke to a lawyer in the middle of COVID, just in passing, and they said that their probate service had gone through the roof because of the amount of people killing themselves and not dying from COVID. So moving forward, we have to think about a whole plethora of information and data that's out there. And at the moment, we are still not prepared. We're still using a 1918 model. We have not got a conducive model that would reflect the modern disease and the modern culture that we live in. And that scares me more than actually dealing with a disease in itself. So, thank you.
So I would like to entertain 2 questions from the floor now. If you have any question, please raise your hand.
Well, thank you for your wonderful talk. I really enjoyed it. I have a quick question. You are the certified INTERNATiONal manager. What is that, and what is looks like fantastic? Because certified manager informatic. So the very early stage in pandemic, there are so many false informations flow around, and how can you prevent and mitigate those kind of events in the future pandemic or endemic? And personally, in your view, what the best approach or good approach to the traditional model? You mentioned about 1980 model, yeah. So most countries use the traditional model, but how can it change in a positive way? Would you please share your thought about that? Thank you.
Sure. Thank you for your question. First of all, the INTERNATiONal manager role came about because it was identified by WHO that there was 2 parts of the pandemic. There was the disease, and then there was the INTERNATiONal. And it was the information that was being passed by nations, by governments, and also by third parties. So we had to put systems in place so that we can actually look at the origin of the story. There was lots of conspiracies out there, as you can always imagine there is, and we had to get to the bottom of where these stories originated from. So one of the ways that we manage infodemics, and I think one of the best ways, is that you have to be risk-facing. You have to see what the narrative is at this moment in time. And if you know that a story is going to be coming out about, say, a vaccine, what you can do is you can pre-bunk it, and you can turn around and say, yeah, we've got this vaccine coming out. It will only be rolled out to XYZ population, or it has a, say, 57% effective rate in certain, so you can get the information out there before people start to destroy it yourself. The other thing to do is debunk information very quickly by using a network of infodemic managers. So you work across collectively across a number of nations, and you just talk to your colleagues and see, you know, how they're dealing with it, what they're dealing at that moment in time. And I think for us, as a community of infodemic managers, we have found that no particular person knows the answer. We rely heavily on our networks and our data networks. And, you know, I think that's why events like this here today are very, very important, because we need to be in a room with like-minded people so that we can plan for the future pandemics. And I think the second part of your question really is about this. It's about the discussion. And we've got to have the agility and the ability and flexibility to be able to adjust to what is being given us on a daily basis, and not as we saw in the UK. The UK Health Service has two arms to it. It has the arm of like-minded healthcare professionals like myself, who are research-formed, evidence-based, and most people in the health service, nurses, paramedics, theatre technicians, are all trained to master degree level now. So they believe nothing and they question everything. They purely are academic, as well as some truly gifted clinicians. However, the NHS has an administration side, and majority of these people are very set in their way. Their level of education is level 3, which is a bit, like I said earlier, the reading age of a 12-year-old. That's about where it is. So when they're taught their job and how to do hospital administration and bookings and such like, that's the way it is. There's no changing it. We've always done it this way. We're not going to change our process. If it says you have to be here at 9 o'clock to see the doctor at 10, that is what you'll do. So for clinicians, it's really difficult. And I think, for me, ISO 7101 bridges that gap between the admin burden of a health system and the healthcare professionals of the future, who are, you know, truly amazing. When you come into contact with them around the world, I get blown away all the time. Thank you.
예, 감사합니다. Certified Informatics.
Thank you. Please show your hands for Mr. Stephen Vanbo.
Final presentation of the first session. Today's symposium, we started preparation starting this spring. We wanted to include various pandemic cases from all around the world. This time we will hear from Africa. It's Ghana's case. During pandemic period, Ghana and Korea had a very close collaboration. This March from Ghana President, Korea received an honorable award. From Kopo Technical University, he is majoring in molecular medicine. I don't know exactly what molecular medicine is because I'm not an expert in that area. But anyway, with a molecular medicine major, the speaker is a very active expert in a related working group. Let me invite Mr. Francis Usher to learn more about cases in Ghana. Please give him a big hand.
Thank you very much. Good afternoon, and thank you for having me and the opportunity that you're giving to me. At least before I came here, I knew about Quaker. They have been supporting Ghana in a lot of facilities in the health sector. So we are grateful to you. So I'm presenting on behalf of Ghana, so I'll share what went on in Ghana. So this is the content of my presentation. Sorry if I want to stand here if you don't mind. So this is the map of Ghana. So we have about 16 regions, and we share borders with Burkina Faso in the north, Cote d'Ivoire to the west, and then Togo to the east, and then Gulf of Guinea to the south. So this is Ghana. We have a population of about 30.4 million, and we have about 216 districts across the country, and we have female predominance. So this is the map of Ghana. I also want to share with you the health structure in Ghana. So we have the Ministry of Health, that is at the top or the peak, and all various agencies that falls under the Ministry of Health. So we have the teaching hospitals, we have the Ghana Health Service, QUISA, government hospitals. All these are agencies under the Ministry of Health. But the major agency under the Ministry of Health is Ghana Health Service. So during pandemic, Ghana Health Service was responsible in terms of coordination, everything about COVID. Ghana Health Service was responsible when it comes to logistic management, supplying equipment, and all other supplies were done by the Ghana Health Service. So they were major stakeholders. They were collating all the data, and they were feeding the country with everything that was going on in Ghana. So they have, under Ghana Health Service, we have the headquarters, we have the regional district, and then sub-district. In Ghana, we have hospitals of about 321 hospitals and about 760 health centers. Health centers are the smallest units in the healthcare delivery system, and we have about 601 laboratories. So this is the level of reporting. So the level of reporting starts from the CHIPS. That is the basic unit or the building block of the healthcare delivery in Ghana, followed by the health centers and then the polyclinics. So this is where the diseases start from, or this is where we are supposed to pick up the diseases and then report to the top. So as I said, we have 16 regional hospitals, and we have 6 major teaching hospitals. Now, so in terms of preparedness in Ghana, the main aim was to prevent, detect, and then to respond to the COVID. And by and large, we try to put in a system to ensure that we strengthen the public health to be able to handle the COVID. So when the report came from WHO that there's a pandemic, there was a team that was put together to conduct a baseline assessment to be able to determine our preparedness. And so that was done by the Ghana Health Service, as I said. And so they started training individuals at the point of entry, especially at the Kotoka International Airport. And the team was also put together to ensure that they're able to do proper contact tracing across the country. Now, as I indicated, the government played a critical role. Initially, we had challenge with finances, but there was commitment, absolute commitment from the president, who voted $100 million to support our preparedness and response to COVID. So around that time, we also had a drone that was imported to the country for the purposes of some other, for purposes of delivering medicines across the country. So that was around the time that COVID came, and this was led by our vice president. And so this drone technology was helpful during the pandemic. And also before then, the country had imported 300 ambulances into the system. And so all this helped in the preparedness towards the COVID. Now, as we all do know how the disease started, the first 2 cases was confirmed on the 12th of March 2020 in Ghana. And we took cognizance from the fact that when the Ebola was coming, we prayed that it didn't get to Ghana. And fortunately, we didn't get it in Ghana. So this time we're still praying that the COVID will not come to Ghana. But one morning we woke up and the Minister of Health made pronouncement that we had 2 confirmed cases, and that's how the country woke up. So at some point in time on the 28th of March, the president had to impose a partial lockdown because of the spread of the COVID. And there was community transmission by mid-April. And then by 25th May, that's roughly 3 months into the COVID, we have already had 34 deaths with about 7,000 cases. But at the end of it all, we ended the pandemic with about close to 1,500 deaths and about 171,000 confirmed cases. So these were the mechanisms that were put in place at that time. So there was ban on public gathering, schools were closed down, churches and mosques were all closed down. Then there was also lockdown. All the point of entries were locked, and there was mandatory quarantine, and then partial lockdown for Accra, which was the capital, and then the Kumasi. These are the central activities in Ghana, and that's where the diseases were spreading. So these 2 places were completely locked down, and there was also mandatory face masks. So the only preparedness that we've had as a country in terms of pandemic was the H1N1, SARS, and then the Ebola. So before then, we didn't have much preparation. Okay, so the Ministry of Health and the Ghana Health Service put together a team and a system to be able to hold this. So committees were formed, major committees. One of the committee, that was the coordinating committee, was chaired by the president of the country himself. And all these things helped and facilitated how we manage the pandemic. So the emergency response hinges around this. I will not go through much, but the issue was about case detection, confirmation, contact tracing, and recording. These were the key things that the country was working on to make sure that the disease does not spread and be able to go to overcome the disease. Okay, again, the response hinges around the coordination, disease surveillance, laboratory diagnosis, and case management. Okay, and the rest of communication and then security. These were the areas that our response hinged on. We will try as much as possible to ensure that we improve the disease surveillance system and also to improve the laboratory diagnosis. I'm laboratory bias, so my interest is mostly on the laboratory. Okay, so there are a lot of programs under the healthcare delivery system. So we have the National AIDS Control Program, National TB Control Program, National Malaria Elimination Program. All these things are programs, so all of them came together and provided logistics to ensure that we fought against the COVID. Okay, so initially we had challenge. The challenge we had was that the clinical facilities, the clinical laboratories did not have the equipment and things to be able to handle the cases that were coming in terms of testing. And that was a major issue. So initially we were using Noguchi Memorial Research Institute. So that was the only institution that was doing PCR for COVID testing. And then later, other facilities, to the extent that even the National Veterinary Service, the vets even were more equipped in terms of testing than the clinical service. So they also came on board to help in the testing, and then other few facilities also came on board to ensure that we did the testing and were able to confirm most of our cases. As we speak now, we have the Gene Expert COVID-19 that is distributed across the country that is used to do antigen testing across the country. So there were initial challenges. As I indicated, we had few testing sites. We didn't have enough testing sites. And reagents and logistics were a problem. It was a problem because of uncertainties. People did not know whether the logistics would be coming, so some were hoarding some of the logistics, causing artificial shortages. Okay, inadequate PPEs and not adhering to protocols, and also had problems with vaccines. And when vaccines came, getting the people to accept and respond to it was also a major problem. So as at now, we had about 25 million Ghanaians who have been administered with various forms of the vaccine. Some have received the first dose, second dose, and then the booster. So that is very encouraging for the country. Now, moving forward, I'll be able to share with you our strength. So our strength is that now we have a response plan. So in case of any pandemic, at least we have a plan that is available to be able to help it. We have trained enough human resource, and the fourth one, the integrated disease surveillance, has also been established across the regions, which means that people are well informed about emergency preparedness. Rapid response team are also available, and we are also operating with One Health approach, where we involve the environmental people, we involve the veterinary, and then the human, all of us combined to be able to ensure that we fight any future pandemic. Now we also have mobile laboratories at the point of entry. And at this, I want to say that I was one of the consultants that did that work for UNDP and then JICA to get mobile laboratories for the point of entries in the country. And we also have National Vaccination Center that also has been established. So in case we have to prepare our own vaccines in country, we'll be able to do so. We also have some weakness, and the weakness about our inadequate laboratory testing capacities is also important, which has to be strengthened. Of course, lack of funds and budgetary allocation to some of these things are major problem. Now the threat, we all know that coup d'etats is a threat to us in the sub-region. As you will recall, in recent times, there's one in Gabon. We also have some in Niger, Burkina Faso, and these are close to Ghana, and they could be a threat to our future preparedness. So there's going to be emerging and re-emerging diseases for as long as this thing continue to exist. It means that we have to prepare for the future. And we've had yellow fever, Marburg, monkeypox, Lassa fever, and all these things, we've had them in our country, and we do not know the next pandemic that will come. And we need to prepare for them. So we recommend for further, we want to equip the public health laboratories at the regional and at the district levels so that we will be able to diagnose any epidemic that will come in real time. And we also want to improve the sample transportation system so that in case there's further tests and confirmation, we'll be able to do so. So thank you very much for the opportunity.
Now we will take questions from the floor. If you have any question, please raise your hand. Seems like there's no question. Sorry to keep asking questions.
When you use the logistics to solve the logistics problem. Actually, we used drone for disinfect some infected areas, but the recommendation regarding the preparation for next pandemic, you mentioned about the sample transportation is very critical, one of the main issue. So, have you ever tried to use drone for sample transportation?
Okay, so thank you very much. The capacity of the drone is not from the grassroots. It is from the top to the bottom. We do not have it at the district and at the regions. Okay, so if we have them at the district, then we could have been using it to transport sample to the regions. But we have it at the regions, so we are using it to disseminate medications and things down. But we don't have it to be able to transport things up. Thank you.
Any additional question? Any further questions from the floor? If not, we would like to conclude the session. Another round of big applause to Mr. Francis Usher, who flew a long distance. With this, we'd like to complete session 2. Now we'll take a short coffee break. So enjoy your coffee break and be back by 4:15. So please enjoy your coffee. In the back of the hall, refreshment, coffee, and water is provided. Feel free to enjoy them.
will going to start the session. 네, 밖에 있는 분들도 좀 착석해 주시기 바랍니다. 네. 정말 한 자리에서 이렇게 그 여러 나라의 상황을 확인할 수 있다는 게 상당히 럭키하다는
hear about experiences from different countries, and I feel very lucky to share these experiences. And our next presentations are also very meaningful and informative presentations. So after the coffee break,
네 분의 연자가 계시는데요.
we were supposed to have 4 presenters, but Dr. Andres Hernandez
last minute canceled.
was not able to make it due to personal reasons.
못 오시게 돼서 양해를 구하는 말씀을 해주셨고요.
So we would like to ask for your kind understanding.
여기 온 사이트에서 발표를 하시고,
And we have 2 other presenters that will be giving their presentations here, and 1 video recording of 1 presentation. And at the end of this session, before the closing remark of Dr. Chong Kim, we will have Director Choi briefly wrap up the sessions for today.
그래서 이제 여러분 혹시 그 Out of Africa 영화 보신 적 있어요?
So, have anyone seen the movie Out of Africa?
정말 좋아하거든요. 5번 정도.
It is one of my favorite movies. I've seen it more than 5 times. I long to go to visit Kenya,
못 가봤지만 정말
which I haven't had the opportunity yet, but I will gladly introduce our expert from Kenya.
전문가를
So let me briefly introduce expert from Kenya, Ms. Sheila Charono is from Kenya Bureau of Standards on quality medical service management. She has been working more than a decade. In addition, she is a public servant for standardization and strives to work for poverty eradication in Kenya. And as a member of the ISO, she has made many meaningful contributions. And also a leader of the African Regional Standardization Organization, ARSO. And in developing many items on TC304, Ms. Rotich made many valuable comments. So please welcome Ms. Sheila.
Good evening to you all. So I'm Sheila Cherono from Kenya. I'm a standards officer, and I would like today to talk about Kenya's preparedness to COVID and its responses. So the outline of the presentation will be Kenya's profile, and then the preparedness, how COVID was in the country, our preparedness, the implementation strategies that were used, and the challenges in the sustained response plans. So this is Kenya. You can see it there. It's in a very strategic position. It's connected to other countries, and you can see it's next to the Indian Ocean. So for the other countries, when goods are coming in, most of them pass through Kenya. So it's very strategic when it comes to production and distribution, based for Africa, Europe and Middle East, South Asia and other Indian Ocean islands. So when it comes to demographics, the governance, we have the national government, and then we have 47 counties with 304 sub-counties. And the total population in Kenya is 54 million. That is according to the Kenya National Bureau of Statistics. So if you can see our population distribution, when you look at the people above 65 years, they make up only 3%. Most of the people are between the ages of 15 to 64. And those, again, who are between the ages of 0 to 14 make up 37% of the population. So we have 9,696 health facilities in the country. 3,000 of them are from the private sector. 4,000 are government-owned, and the rest are faith-based organizations, NGOs, and community-based organizations that put up health facilities to support the ones by the government, because there are very few. And according to WHO, the ratio of the health workers compared to the population, the ratio is 13.8 healthcare providers for every 10,000 individuals. And this is below the threshold for the WHO recommendations, where it talks of 44.5 providers for every 10,000 individuals. So that means that the number of healthcare workers in the country are far less from that is recommended by WHO. So how did COVID come into the country? There's a lady who had gone abroad, and she came back to the country. On arrival, she was told to self-quarantine, because that was the rule once COVID was announced as a pandemic in the whole world. So she was told to self-quarantine, and if she had any symptoms related to COVID, she was supposed to go and present herself to the nearest health facility, which she did on 11th March 2020, and that began the genesis of COVID-19 in the country. So, but we see that when it comes to COVID-19 in Africa, we have a very small proportion of only 4%. So scientists were wondering, why is it that in Africa, the number of people getting COVID-19 was that low? And there were different hypotheses that were being brought out, that maybe it's because of the warmer climate conditions in Africa. Maybe because, as you can see, the distribution of the population, we have more younger people than the older ones. There was also another one that there were low cases of people who are being tested. So maybe we don't know the number. Maybe the number is bigger than what is there. Another one was because of population-wide immune priming. That means that there are very many vaccines that we get for the different diseases that we have been getting as a country. And maybe the immunity of those vaccines enabled us to manage COVID-19 better. And then the other one was the genetic factors. When it comes to us being Africans, maybe we are able to manage the disease better. But the truth of the matter is that in Kenya, as well as many countries in Africa, we have seen other vaccines, other diseases that have affected us previously. We are looking at Ebola in our country. We have HIV, we have malaria. So therefore, because of these previous outbreaks, our country has already had mechanisms to prepare ourselves and also how to respond in case of such eventualities. So this is one of the main reasons why COVID was managed better in our country, despite the obvious poor health conditions. The healthcare workers that are very few in the country. There are very many reasons that I'll cite down as we go on. So this was the main reason, one of the main reasons why we were able to manage COVID-19 better. Another point to note is that there was leadership involvement in the management of COVID-19 right from the time that it was announced. The president himself was part of the interventions that were to be put in place. And we could see greater coordination capacity. There was better use of the resources that were already available. there was harmonization of public messages, because it would be that it is the government who now speaks and tells us what we need to know. And so therefore, it was coming from one place. And those were places that it was easy to influence the citizens. And there was a clear division of labor among those people who are implementing the different interventions. So you'd find that there was no two people doing the same thing and leaving out one type of intervention that was required. Another thing was Kenya used, because, you know, in our country, there's high, there are integrity issues when it comes to maybe corruption. We do not believe in the quality of products that we have in the country. And so therefore, the government used other partners to make sure that the interventions that were put in place were followed. Like you can see from the picture, this is a pastor, a priest. In Kenya, when it comes to religion, the religious leaders are respected and listened to. So what was done was the vaccination, because there was really poor uptake of the vaccines in the country in the beginning. So they would take the vaccination to the churches. And then now the pastor is the one who will first be vaccinated. And now when someone sees, yes, the pastor is being vaccinated, they were more willing now for themselves to be vaccinated. The use of the radio stations, youth leaders, and other key influencers. So what they did, they went back to the community, to the people of influence back in the community. And they are the ones now who are spreading the word when it comes to, you need to self-quarantine, you need to go to the hospital if you think that you have COVID symptoms, you need to have the vaccine. So when you're hearing it from the people that influence you, it was now easy for them to take up these interventions that were being brought out. Another thing that was done was that the information that was being provided, given that we have the cell phones that are there, the technology that is there, there was a lot of misinformation by the media. So what happened? The government, using the risk communication and community engagement, provided accurate information on the local channels. Every single day they would announce, this is the number of COVID-19 people that we have, this is what we are doing. And it fostered people to understand exactly what is in the country, apart from just getting the information right from the social platforms. Another thing was that there was a lot of trying to reinforce trust by working majorly with the vulnerable in the community. They had programs for the youth, the persons living with HIV, the older people, and the religious groups, to enable them to, they supported them so that they could build trust for them to uptake the interventions that were being put across. Another thing that was happening is that also using the mobile phones, the integrated SMS messages, so that from your house, from your phone, even if you're not getting in contact with the people that are surrounding you because maybe of the social distancing, there were various topics that were being brought on COVID-19. And there was a chance for you to give feedback using the SMS platform to say, for example, if the information was good, if you've seen any other challenges when it comes to COVID-19. And then there was a mechanism that was established for data collection, and this was through the National Bureau of Statistics. And this was, there was a lot of financing that was going into the bureaus and also to the research people so that they could go out and get the information that is required to know the level of implementation, how it is when it comes to the perception when it comes to COVID-19. And they worked hand in hand with the NGOs that were already there because of the other epidemics that were experienced in the country to be able to get technical assistance, maybe competence building for the healthcare workers that were there, for the people that were going to influence others in the community. The NGOs supported them by providing them with the correct information. Through the body that was created to deal with COVID-19, there was availability of resources that were set aside to manage the responses and the emergencies that were going to take place. And this went a long way in ensuring that the emergencies, the preparedness, and the response to COVID-19 was done effectively. So what were the implementation strategies that were used for COVID-19? First of all, there was a ban on air travel into and within the country. So only citizens, Kenyan citizens, and foreigners with valid residence permits were allowed into the country. And when they got into the country, they had to be put on mandatory quarantine for 14 days. All local travels were cancelled, and they were only reopened in July 2015, 2020, and the international ones were opened in August. So there was that good time where there were no traveling in the country and within the country. Another one was the imposition of the nationwide curfew, and this was between 7 p.m. and 5 a.m. from March 2020, and this went on until 13th October the next year, 2021. Cessation of movement. The big towns were the most affected by COVID-19, and therefore there was a ban for the movement outside the big towns, and this was worked very well. But when they just opened up the borders, that is when the third wave of COVID-19 hit. So as soon as they would open up, people would start moving, and then we'd go back to the same problem. So what they did, they closed it up again until they were sure now that the spreading of COVID-19 had reduced. Another one was prohibition of social gatherings. And this one included the places of worship. There was a time people were not allowed to go to churches. There was closure of in learning institutions. There was the reduction of the number of people that could use the public transport. So you'd see if, for example, a bus that would carry 23 people, during that time would carry only half the number of people that it used to carry before. And then there was mandatory COVID-19 vaccination. It got to a point where the president would ask that everyone should be vaccinated. It was mandatory. If you were not vaccinated, you would not access the public services. But again, the High Court went in and refuted that and lifted that mandatory vaccination because it was really affecting us when it comes to the human rights. I will explain that as we go down. So again, there were, as you had seen from our map, the bordering countries, there are some countries which did not want to adhere to the COVID-19 preventive measures. And so therefore, at some point, Kenya had to close down its borders and only allow people who had been tested for COVID-19 or received vaccination to access the country. This again led to a lot of political instability between the two countries. And with talks later, at least they came to an agreement and both decided or agreed that for their people to cross over to Kenya, they had to be tested or vaccinated against COVID-19. So what were the challenges when it comes to these interventions that were put in place? The first one was the violation to the rights to health. During that time, it was found out that there was a reduced number of the pregnant women going for their antenatal clinics, a decrease of 39%, which was very high. Another one was a 32% decrease in the skilled birth deliveries. So people were giving birth at home without help from a healthcare worker. There was also a reduce in the number of children that were being immunized against the other diseases. There were people who were going for cancer treatments in the hospital. And because of they were not allowed into the major towns, for example, for instance, cancer, the facilities which offer cancer treatment are usually found in the major towns. So when they locked it up and said that if you cannot enter the major towns because during the lockdowns, the people who are suffering from the chronic illnesses really had it rough because they could not get the treatment that they required. And apart from that, there was cholera outbreaks in different counties because, you know, some areas of Kenya are made up of slums. And so you find that these are very small setups where we do not have, the basic hygiene cannot be practiced. There are no toilets for people to go to. There are no places where they can find clean water. So you'd find that given that they are now confined in the slums, they have nowhere to go, they cannot go to work. The cholera outbreak came back again. Financial constraints. For majority of the people in Kenya, the people in the high class are usually very few. The people in the low class make up a majority of the population in the country. And when they go out to work, the money that they receive is what they're going to feed on when they come back at home. So when you tell them that there's no going out, you'll have to work from home, they have nowhere to go. So what did they do? During the lockdown, everyone left the big cities and went to the rural areas. And in the rural areas is now where we are finding the old population, those above 65 years. So now, because they are more vulnerable, they were now at risk of the COVID-19 from the people now who are running away from the major towns because of the economic constraint that was happening there. Apart from that, the COVID-19 testing kits, as much as we are saying that the interventions were being put in place, there was finances for them. It reached a point that the testing for COVID-19, the kits were not available. They were not enough. And so therefore, this created a constraint. The PPEs that they were being told to wear, especially by the health workers in the hospitals, at some point they were not enough. And therefore, this means that the intervention that we are talking about, that they should be in full PPE, that they should hand wash all the time, when that is not available, it becomes a crisis and a risk to the healthcare worker themselves. The equipment to support life for patients with COVID-19 in critical conditions, you'd find that most of them were found in the major hospitals. So the ones that would not access these hospitals, and the number at some point really increased, you'd find that they were not getting the critical care that they needed. Then there's lack of good roads and transport systems, poor electricity infrastructure, which led to limited access and supply of the reagents necessary for testing. This is especially in the border points. So what we can say is that the regulations, the policies, they are there in the country. Now, the biggest problem is implementing them. When you're talking about integrity, we are talking about corruption, you'd find that there are very good systems in place to ensure that we are controlling COVID-19 as we should. But if the funds are being misdirected or not going to where it was required, we are not able now again to handle the COVID-19 crisis as it should. So this was the other ones. We are talking about long delays for collecting samples, sometimes mixed diagnosis. We are talking about porous borders in the country that do not do COVID-19 testing. At some point, our neighbor Tanzania did not implementing the COVID-19 precautions that globally had been arrived at. And because our borders are porous, it would mean that as much as we are trying to implement this as a country, there's a challenge now when our border country is not doing it. And it was so bad that at some point, there was that shift between the two leaders on what needs to happen. So at some point, Tanzania was like, we will not accept any trucks with Kenyan drivers to pass through our borders. And Kenya was like, unless they're tested for COVID-19, they will not pass into the country. So who suffers the most? It is the drivers that need that money. It is the business people that are transporting the products in the trucks that pass through the different countries. So thank you.
So I feel like I almost visited Kenya now. Any questions?
Yeah.
그 테스트를 어떤 종류 테스트를 했는지.
What kind of tests have you done? You talked about the shortage of test kits. In case of Korea, in the beginning, we did nuclear acid test. So there was a shortage of test kits. But later on, rapid antigen test, which allowed self-test, was distributed massively. So what you should do is just send out the test kits. So it was not a big challenge. What was the situation in Kenya? What kind of test method and test kit were utilized? Do you have relevant data to share?
Yes, there's data on that, number one. First of all, in the beginning, Kenya was not able to test themselves. So what happened is that samples were being collected and they were taken to South Africa for the results to come in. And now you can see the problem when you are picking samples. You don't know the integrity of that sample when it gets to South Africa. So with time, the rapid test came in, and now the reagents were coming into the country, and that's how now they were distributed to the different areas of the country.
혹시 또 다른 질문 있으신 분 계실까요? 네.
Any other questions? If there are no further questions, please give her another round of applause for her wonderful presentation. Thank you.
여러분 혹시 커피 좋아하세요?
Does everyone like coffee? In all events, we have coffee. And when I think about coffee, I'm envious of Italy. Italy does not produce coffee beans, but they're very clever. Cafe latte, cappuccino, cafe mocha, and all these brilliant coffee recipes were made in Italy, and they produce coffee machines, so making a lot of money from the coffee industry. So that means they have standardized the coffee recipe. So from African countries that do not make coffee recipes, Italy is located far away, but Italy still has the coffee recipes made by themselves. So I will now welcome Mr. Franco Fontana from Italy. Before having him on the podium, let me briefly introduce Mr. Fontana. Mr. Franco Fontana has rich resume. He is from Intertech. He works as a Service and Person Certification Manager. He has a degree in Political Economy with a master's degree on application of quality certification models. So he's an expert on the application of quality certification models. And I see a lot of numerical figures in his resume. I see 96 working groups that he's following, and that he's participating in revising ISO 17024, and he's definitely an expert in certification, accreditation. And he has many personal hobbies, and I'm envious of this: climbing, mountain climbing, hiking, biking instructor. All of these hobbies are the things that I personally envy. So please welcome Mr. Franco Fontana. His presentation is titled How the pandemic response was in Italy.
Thanks for the invitation. And I try to approach with a different point of view the pandemic response. And so you can, and yes, it's working, yes, okay. It's correct. I have involved in 97 working group and in a lot of working group of ISO. And the reason is because some years ago we create a confederation of association, and so they delegate me to work on this.
yes, Intertech pay me the salary, but I develop a lot of standard for the national standardization body. And thanks really for the invitation. And as I said, I would like to approach with a different point of view. So thanks, Sun, and thanks for KKU University. And what's happened? No, sorry. What's happened in Italy? In Italy, I don't know how you know, how much you know about what's happening with the pandemic situation. Was the first country in Europe and the Mediterranean area that have the impact of COVID. Was absolutely unexpected and underestimated, absolutely. So the first 3 months for Italy was a strange situation. The first case was in the north of Italy, in Bergamo, and everyone said, oh, it's just an influence, it's nothing. But 2 weeks later, there was such a match, and no one take care about isolation or something like this. But what's happening is that after 5 days of the soccer match, there was a lot of people with COVID, and there was 2 different cities. The match was with 2 cities. One was close to Bergamo, and there was another city. In these 2 cities, in 5 days, all the hospital was full, and start a problem because we had a lot of death. In Italy, I think that every person has someone in the family or some friends died. So very, very big impact. And I don't want to go in details because I'm not a doctor, I'm not an expert in medicine, but for sure what we done it was to close everything. So everything was in lockdown. And I don't know, feeling for you, but for Italian people, and also for European people, lockdown is something really hard, strange, because we normally move without any problem in any country, in any region, for everything, for holiday, work, family, no problem. So say to Italian people, stay at home, is like to kill them, really. So the situation was very, very dramatic. And I appreciate a lot what said the other speaker, because the social media makes a lot of chaos, a lot of wrong news, but unfortunately also the media. So every day there was some different communication, and every day changed everything. But for sure the most impact was on the social aspects, for sure. But I don't want to go in detail on this because, as I said, I would like to approach from a different point of view. Face mask. The first thing that the government said was to put the face mask, but there was no face mask. In 1 week, everyone, all the reserve all the stock was finished, also for hospital. So, no information, which use, what's different between, how to put them, nothing. Face mask for basic model or nuclear face mask for the people was the same. So it was absolutely difficult. And also hand sanification, air sanification, surface, what to do, what product to use, how to use, where to find them. But the problem was that there was a lack of this product, of every product. So mask, sanification, everything. So what we decided to do as standardization body and accreditation body, because the government was really managing an emergency very big, we decided to distribute standard. So the accreditation body and the standardization body give for free in the website of the National Standardization Body all the standard connected to COVID use, okay? I don't go through everyone or each one, but a big list of documents and standard. And this was for free distributed very quickly, so the decision was taken in 1 month, 2 months. And this was really helpful because, as I said, the production was normally in China and the market was closed. Nothing could arrive from China. And so the people start to create from their home a mask at home. And the situation in the hospital was so critical that a doctor that made snorkeling discovered that the mask distributed for snorkeling could be, with a little change in this part, adapted to use in the hospital. And they made an agreement with a company that created the yellow part, because there was no support for artificial pushing for the oxygen. So very, very critical situation. Also, a lot of companies that produce wine or something like this change the production to produce alcohol to sanification, because there was nothing. All the production was outside Italy. So we have to convert the production and go back. You know, Italy for fashion is quite good place. A lot of companies that produce dress make masks, convert immediately. Also because the market and the shop were closed. So if you want to work, change the approach. And distribute the standard was really useful because they had the requirements to create or to convert the production. The second approach, as you know, Italy is a touristic country. The 20% of our economy comes from tourism. And so we start immediately to think how reactivate tourism, because everything was closed. The government didn't give guidelines, so we decided to create standards, but with a different approach, because I don't know if you know that there is a difference between a standard and a workshop agreement. But we decided to do a workshop agreement because standards is too long to be created. The standard is based on a consensus. It normally takes 2, 3, 4 years. So we move to workshop agreement to be more quick, more easy, less consensus, but faster. And we create, as you can see, look also to the data. July 2020, so in 4 months, we create standards. Because we have to go quickly, because the tourism was really in a big crisis. And we start with the association to create some standard. also for weddings. No weddings for 6 months, 1 year, no weddings. The government said no wedding because it was critical. So we start to do, but all of these are guidelines. The difference between a guideline and a standard with requirements is that the requirement standard you can certify, if a guideline you can certify, but was anyway useful for the companies, for organizations, for tourism and so on. This was other standard, and they ask some question to me about the standardization, how the impact. And for sure, standardization is a good opportunity to support situation like what happened with the COVID. And it is really important because could create common interface to speak, analyze, and have a common language, common process. This is really important. But two keywords, standard and prevention, has a combination that is quite strange. And this means that we have to change how we write a standard. Because we have also to verify how we use the standard. I want to go quickly in. I will explain later. Anyway, these documents are available for everyone. I think it will be distributed. So, what we learn that we react too late, for sure. We didn't anticipate, but we react anyway too late. And I think that the very big problem is also the implementation and how popularize a standard. No one knows a lot of things about standard. The stakeholder engagement is sometimes good, but you said that there is not so much expert in the working group, but for sure the stakeholder engagement is really, really important. Government, certification body, accreditation body, organization, companies, industry has to be involved. Because if you don't know the standard, you don't use the standard. This is a big problem. And the conformity assessment, that is the certification, is based on the requirements. So if we don't put into the standard requirements, we can't use them to certify. Yes, it's interesting, could be a guideline, is useful, but we can't use the conformity assessment activities for any kind of certification. Management service, person, process, this is very, very, I think, important. This is not, but this is really awful, in my opinion. This is the 4 standard that you develop with the work UG4. There is no UNI under ISO. This means that these 4 standards are not distributed in Italy. No one knows that there is these 4 standards. They are not translated and they are not distributed. Yes, if you know that it exists, you can buy, but no one tell or distribute or explain that there is 4 standards published. This is terrible, because great standard, no one knows. Italy is in this situation. So the other important thing, as I said, is the timing. COVID, it was in January 2020, first standard 2022. So this is the reason because we have to change approach. Use the workshop agreement. It's not a standard, could become later, but in the first time it's fast. And also take care to this one. I don't know if you know this standard, but when you have to certify 9001 a company, you need accreditation 17021. If you want to certify a person, you need accreditation 17024. This one, 17029, is really new one standard of accreditation that take care about future. Is the only accreditation standard that looks to the future, was built for sustainability approach, but this could be useful also for your project. Why? Because we have to take care to 3 different times: past, now, and future. So the 17029 works in this way. We can have a program like a scheme, a certification scheme, or a standard that use the verification to verify the present and the past. And when you are doing the audit, you can check also what you have supposed or the objective that you have given for the future. So the next year, when I do the audit of certification, the future became the past. So I can check and validate what you have done. If you have respect your objective, or you have failed, or if you made change, or something like this. This is a completely different approach. And if we have to speak about pandemic response, for sure we have to look to the future. So when you write a standard, take care how you use it or you will use it, or how certification body or accreditation body use it. Unfortunately, there is a lot of standard, beautiful standard, with into a lot of knowledge, a lot of important things, but they didn't take care how to use it. And so sometimes these standards are unusual, are unknown, are not useful for the market. And this is a lost. Okay. So, thanks a lot, but my message is, when we write standard, we have to take care how we use it. And also take care to another one thing. If we write a standard for the process, for management system, or everything, the process can fail if there is no person with the competence to manage the process. So ISO is starting to has also already developed some standard within the first part written the process that you have to verify with the requirements, and the second part there is the competence requirements from the person that not for who make the audit, but for the person that is into the process. So work in the field of the process. This is my opinion and suggestion. Thank you very much.
Thank you very much. It was very important message delivered in a comparatively short time. The first point was that it is unfortunate to have beautiful standards not advertised enough or not understood enough. And the second important point was the fact that for international standard writers, they're only given about 36 months. So they only have 3 short years to write these important standards. One American expert that I met has said that they intentionally take 3 years because they want to have a slow conversation as long as possible.
You recommended IWA. I
So rather than having me ask the question, does anyone on the floor have question regarding many important points from the presentation? For instance, related to should we use shall, or should we just use the word should? It's called normative verbs that are often used in international standards. Depending on what type of verbs we use can have an impact in international standards. And there are many creative approaches that Italy took. So does anyone on the floor have any questions?
Go ahead, please. Please use mic.
Hi, thank you for your wonderful presentation, and it's really inspiring. As your presentation, you talked about the UNI standard. I'm wondering how can you certain the title of the standard? I'd like to say, how can you ascertain which kind of standard we need to made in these urgent, situations? So this is my question. And another one is I'm wondering, is there any key factor we can implement this UNI standard? So that's it. Thank you.
Certification is a voluntary approach, but also standardization. So, as I said, I represent a consortium of association. So, UNI only opened the door and react to the pressure of the association. So, for example, we spoke about wedding. There was 3 main big association of wedding planner that was obviously stopped by government because they said no wedding, and so they need to work. And so they asked to the consortium, to me, what we can do. I said, we can try to create a guideline to define how could you organize a safe wedding with the COVID situation. So it's not an action that coming from the government, it coming from the bottom, from the association that need to restart to work, and so made quickly the document. The risk is that the consensus is not so big because 3 associations, yes, represent most of the market, the wedding planner, but not all the market. But it was the only way to do quickly. But anyway, in the process of the standardization body, also when you have a workshop agreement, there is, before the official publication, an unofficial publication online where everyone can say and make comment and say, no, this is stupid, no, this is good, no, this I don't like, everything. Of course, the working group, after take care of all the comments and solve and reply and answer. But who do first is who arrived first in UNI. So it was the market, the association that make pressure. For sure, what's happening is that the first one give the inspiration to the other, and so start, and also for other convention situation, they made this guideline to manage the COVID situation. This is how we done. For the other standard, for the other request, depends for the working group. In my opinion, but it's a strange opinion, I don't like management system. There is too much, and most of the time management systems are unreal. It's more a process, not a management system. In ISO, there is 37 management system standard. No, there probably are process, vertical process, and the approach also for the certification is different. When you certify a management system, you have to look to everything in the organization because it's a management system. When you have to verify a process, you look to the process with interaction to the other ones, but you are in a vertical approach. And I think that sometimes it's better to use standard for process or service certification and not management system. Because small companies, small organization, anyway, think to management system like something too heavy, too difficult to implement, too difficult to certify, too cost. So the approach sometimes could be changed. And is what I said, when we write standard, we have to take care how use it. Not we wrote, we know, but the others. So organization, accreditation body, and certification body. This is my opinion.
Maybe a comment to add on that. In Kenya, during the COVID-19, we also developed standards, the NWA standards and the PAS. So these were standards that were done because of the need during that time. But in our case in Kenya, the difference is that they must be built by consensus, number one, but it is the timelines that are now reduced. Another point is that for the PAS standards, there are specification standards, and the only rule that is there according to our procedures is that they should not conflict with any other standard that is in existence, and they should complement the regulations of the country and not conflict them in any way. Yeah.
Thank you for your comment. Thank you. Yeah, let me summarize the. Yeah, thank you. Please, 박수 한번 주십시오. 네네. 간단하게 이제 약어가 약어가 나와.
We had very many abbreviations, so let me briefly explain. So POT means publicly available specification. POS is to gather consensus as soon as possible to publish an agreement. It doesn't have to wait 36 months. So you can publish POS as soon as in just 1 year. And the best well-known POS related to COVID-19 was the occupational safety published during this period. POS, as was mentioned in our comment from Kenya expert, must not conflict with other existing standards, and it must not violate any other regulations of a specific country. So when trying to write standards or develop standards as soon as possible, POS is a recommended option. It's a quick option for standards. However, one issue here is that the consensus level is relatively lower for POS, but during the pandemic, it took us too long, as was mentioned by Mr. Franco Fontana. So to deliver and develop international standards in a timely manner is an important point that we should think about. Thank you very much for the productive presentation. We have a video recording of the next presentation.
The next session is from Sri Lanka. Dr. Inoka Shurawira.
발표를 해주시겠는데 주로 이제 이 전문가께서는
Dr. Inoka
콜롬보 의대대학교를 졸업하시고
graduated from the School of Medicine, University of Colombo, majoring in community medicine. And she currently works at the Directorate of Environmental and Occupational Health at the Ministry of Health. She's an expert with a lot of published papers. Although she didn't make it here, she sent us a video presentation. So let's learn what happened in Sri Lanka about COVID-19 and what is the preparedness and response in Sri Lanka.
First of all, I would like to thank the organizers of this prestigious conference for giving me this opportunity to share our experiences. The talk for today is World under COVID-19 Experiences of Sri Lanka related to surging diagnostic demand during the pandemic. The outline of my presentation is as follows. I would like to briefly talk about Sri Lanka. Sri Lanka is a small island in the Indian Ocean. It has 9 provinces with 25 districts. The population in Sri Lanka is 22.2 million. Literacy rate among males is 94%, while it is 92% among females. Life expectancy is 76%, and we have a workforce of around 8.1 million. Out of this 8.1 million, 60% of the workers work in the informal economy. I would like to take you through this timeline, outbreak to a pandemic. Well, on the 31st of December 2019, an outbreak of pneumonia of unknown reason was identified in Wuhan, China. On the 7th of January 2020, it was named as novel coronavirus disease. On the 30th of January 2020, the World Health Organization declared it as a public health emergency of international concern. On the 27th January 2020, the first patient was diagnosed in Sri Lanka. On the 11th of February 2020, this disease was renamed as COVID-19 by the WHO. And on the 11th March 2020, WHO declared COVID-19 as a pandemic. I would like to briefly explain about the COVID-19 situation in Sri Lanka. We experienced 3 waves. The first wave lasted from January 2020 to October 2020, where we had 3,396 patients. The second wave was from October 2020 to April 2021, and we had 92,341 cases. Well, the third wave, the largest, lasted from April 2021 to April 2023, and the caseload was 576,434. A summary of the COVID-19 situation in Sri Lanka. Total number of cases, 672,171. Total number of deaths, 16,842. And you can see clearly the 3 waves. The third wave with a very high case fatality rate. Well, most of the cases of COVID-19 were found from the Western province. It is considered the economic hub in Sri Lanka. And when we look at the age groups, 21 to 60 age group was mostly affected. You can see the male-female representation. Mostly males were affected. Let me briefly describe about the testing. Well, testing was conducted for case findings as well as epidemiological surveillance. Case findings, passive surveillance, active surveillance were conducted. Active surveillance included all close contacts of COVID-19 patients, random sampling of neighborhood of confirmed COVID-19 cases, overseas returnees, health workers, and other frontline workers dealing with COVID-19, especially the Triforces and police. All patients admitted to hospitals, inward patients. There were a lot of active surveillance going on during this period. Then for epidemiological investigations, sentinel surveillance, random sampling from communities, and rarely seroprevalence studies too were conducted. Now, how did we do that? Let me explain about the government health system in Sri Lanka. The Ministry of Health provides curative, rehabilitative, and preventive health services. When we look at the curative health services, those are provided by tertiary healthcare, secondary, and primary healthcare institutions. Most of the tertiary healthcare institutions, they have laboratories, microbiology laboratories. Health is devolved in Sri Lanka, and health services are provided through the provincial as well as the district systems at subnational levels. The district and the provinces, they too provide curative as well as preventive health services, especially secondary care and primary health care institutions are there under the provincial systems. At the very initial stages of the pandemic, Medical Research Institute, which is the premier research institute under the Ministry of Health, initiated PCR testing within 3 weeks of the outbreak in Sri Lanka. Additionally, 3 provincial virology laboratories, especially in Kandy, Galle and Anuradhapura districts, they too started the testing facilities. Robert Koch Institute, Germany, as well as Professor Piris from Hong Kong helped in starting testing in Sri Lanka. Ministry of Health took a lot of effort to increase the capacity of lab facilities in government health institutions. They were expanding the numbers of laboratories as well as the testing capacity. Certain laboratories, they were working for double shifts, and certain laboratories, they were even working for 3 shifts. At the height of the pandemic, there were 42 PCR testing facilities in Sri Lanka. In addition to using the government laboratory facilities, university laboratories too were used. They were strengthened and they were used. Public-private partnership, especially private sector laboratories were strengthened, and they too were used in order to meet the increasing diagnostic demand. Rapid antigen testing too were introduced, and drive-through testing facilities were opened up. Mobile lab services were used. Public health staff, especially Sri Lanka has a very good public health system. They were trained for testing with rapid antigen test kit, and the testing was further expanded. Some of the laboratories were automated. Therefore, they could do more tests per day. While all these things were happening in terms of strengthening the diagnostics, every effort and maximum effort was taken to bring down the caseload through citizen education and community engagement. strengthening preparedness in workplaces and transport sector, rigorous monitoring and quick public health action. Just to show you some of the numbers of the tests which were done in Sri Lanka, according to this figure, in 2021, a daily average of around 8,000 PCR tests were conducted and an average of 6,267 tests per day were done using rapid antigen tests. 14 laboratories of the Ministry of Health, 4 laboratories of the faculties of universities, and 4 private sector laboratories were functioning as of May 2021. Let us try to understand the reasons for this increasing demand, especially during a pandemic of infectious nature. Uncertainty of the disease. Most of the things were changing, even the protocols of testing, exit, and even quarantining, isolation procedures, all those things were changing rapidly. People were of fear, and then strict protocols for identification and exit, increased infectivity with mutations of the virus, transport systems favoring via disease transmission, and of course continuation of economic activities. All these things were making people getting the disease as well as an increased demand for testing. We had challenges during this period in terms of diagnostics, certainly financial constraints, issues related to supplies of reagents, test kits, machines. I suppose world over these issues were there. Human resource issues, especially the health staff, was not enough. Issues related to decentralization of lab services, even though the Ministry of Health was taking every effort to expand the laboratory services. It was very challenging. Expectations of the people for more testing. For one thing, they were of fear of the disease, and then they wanted to have more testing. With all those things, the demand was increasing. Well, we had challenges with regard to quality assurance of the testing facilities and then the tests. Additionally, health staff, they were fatigued, they were tired due to the prolongation of the pandemic. Economic and other social issues, political instability, too were very, very challenging for Sri Lanka during this pandemic. In conclusion, I would like to highlight the following. Considering the challenging climate scenarios and changing climate scenarios, we need to anticipate pandemics and epidemics of infectious nature. Therefore, it is critical to develop emergency response plans, and those plans should critically focus on strengthening diagnostics. Platforms should be developed to share best practices of countries so that the other countries also can learn from those in order to better face future epidemics and pandemics in relation to diagnostics. Finally, management systems on diagnostics during pandemics and epidemics of infectious nature should be developed. With that, I would like to conclude my presentation. Thank you very much for your attention.
네, 원격이지만 훌륭한.
So it was a remote presentation. Once again, thank you, Dr. Inoka, for the presentation. Although she's not here, we have a delegation from Sri Lanka.
My colleagues, experts from Sri Lanka.
Yeah, please go ahead. Yeah. Please stand up. Would you please stand up? 여러분 먼 길 오셨는데 큰 박수 좀 부탁드립니다. 네, 감사합니다. 네, 자 이제는 우리가 오늘 예정된 강의를.
So all of the scheduled presentation has come to an end. We've learned a lot from today.
So let's invite Director Choi to share his summary of the presentations that we've heard today. He has especially been working on pandemic response here in Korea and have been working together with the global network on this area. So I would like to ask Mr. Director Choi for his summary.
네, 감사합니다.
Thank you very much. Although I'm not an expert in healthcare, so I won't be able to give you a meaningful insight. But I would like to share a few points that I felt while working in the field of pandemic response and listening to the presentations today. First, I would like to talk about the importance of data, the number of confirmed cases, and the whereabouts or how these confirmed cases came into touch with the virus, and how each country should respond to the pandemic are very important information. And these data, as was mentioned in the Sri Lanka presentation, needs a platform where each country can share their data. So in this era of fragmentation, I think sharing data and information would be the fastest way for us to fight pandemic. And by sharing the data and information, I think we can solve this problem. When I was stationed in one country in the Middle East, I felt that the number of confirmed cases were the data used to decide whether one country will shut down its border with another or not. One presentation introduced us that the countries were colored as green, yellow, or red. But in this Middle East country that I was stationed at, it classified South Korea as yellow type country, restricting traveling of myself and other business people. So our ambassador discussed with the country's authorities on this issue. And we also said that South Korea is doing quite well in managing the number of confirmed cases and managing serious patient cases. But what this country's authority has said that they use Worldometer. The Worldometer website was unfamiliar to us. We have never heard of this website. So according to this website, they show the number of confirmed cases in South Korea. So that's why this Middle East country was putting restrictive measures against South Korea. So I felt like these kind of transparent sharing of information was actually disadvantaging the business people from South Korea. Of course, this was the best possible measure taken on this country's side, but this was my experience. The second point I want to make, we had presentations from each continent. And I think speedy sharing of experience is very important. As was mentioned in Ghana and Kenya presentation, the response to each disease and pandemic became a very productive experience for these countries to respond to other pandemics. We have experienced many things during the past 3 years during the COVID pandemic era. We don't know what kind of disease will become the next pandemic, but I think we have good lessons to learn from. So in that sense, I think ISO TC 304 Working Group 4, as I have mentioned in my welcoming remarks, has its significance. Going forward, hopefully the Working Group 4 will be able to share our experiences in a prompt manner and share national responses as quickly as possible so that we can curb the fear against new pandemic. So that would be all for my summary. I would once again like to thank all the presenters today. Thank you.
네, 과장님 감사합니다.
Thank you, Director Choi. He flew this morning from Jeju Island. Thank you for your encouraging comments. Finally, closing remarks. We were able to enjoy the session today thanks to the effort of convener Jong-won Kim. There is a list of agencies and institutions on the poster, but convener Kim made the biggest contribution. So please welcome him with a big hand. Now we will hear his closing remarks. Thank you. Well, Director Choi literally closed today's conference, so I just want to add more things. It wasn't just me, there were support from other institutions, organizations. So it was a good opportunity to learn from each other and think about future plans. Last but not least, what matters most is to take a group photo. All of the foreign speakers and guests, please step forward.
Come here, and the Korean student or everyone is in front of, under the stand. Then you can on pictures all together, and then we finish this meeting. Please come here.